Hello, everyone. Thank you for joining the 2022 Improvement Activities in Promoting Interoperability Performance Categories webinar. During the webinar, CMS subject matter experts will provide information on participation basics for the improvement activities in promoting interoperability performance categories, reporting and scoring requirements, and resources and support. The presentation will be followed by a question and answer session where attendees will have an opportunity to ask questions via phone in the Q&A box, and CMS subject matter experts will address as many questions as time allows. You are welcome to submit questions during the presentation or wait to submit your questions until the Q&A portion of the call. Now I will turn it over to Katie Moore from CMS to begin.
Great, thank you, Olivia, and good afternoon, everyone. Thank you so much for taking the time to join us today. As Olivia mentioned, today is really our deep dive into all things 2022 for improvement activities and promoting interoperability performance categories. Some of you may have joined us a few weeks ago when we hosted our Mips overview webinar that covered kind of high level of everything, but now we're really trying to get into these more detailed performance category presentations. So again, just today, we're really going to focus on improvement activities and promoting interoperability. And you have our wonderful CMS experts here to give you some more information and to answer your questions. Next slide, please. All right, we can go to the next slide. Thank you. Okay, so here's just a quick run of show what we are going to cover today. So we'll start off with just our general quick few slides on overview of the quality payment program, and then just a few overview slides of Mips, which is our merit-based incentive payment system overview. And most of those slides will probably just be quick refreshers for most folks, but we always like to include them in case we have any new participants on our calls. And then we will get into another slide just to highlight our 2022 annual call for measures and improvement activities that is going on right now. Just provide some more information on where you can get information about that. And then I will turn it over to Michelle Peterman, who will go over our improvement activities performance category and cover all of our basics, and then updates that we have for 2022. And then we'll turn over to Elizabeth Holland. She will go over everything promoting interoperability performance categories, all things you need to know about that performance category, and we will end with some just where to go for more information and where to get some help and support. And then, as Olivia mentioned, we will open up for Q&A, and when we get there, we'll go over more information on instructions. So how to call in if you'd like to. We'd love to speak with you or to answer questions through our Q&A box. And before we get going into the overview of our QPP slides, just want to remind folks that we always post our webinar and then video recording of today's presentation. So don't want anybody to think they have to furiously write down everything we say, because we will always have this information available on our QPP webinar library. Thank you, Eve. Yep. So please check back, and usually about a week or so we have that up and available as a resource to go back and reference if you need to check on something. All right, next slide, please. Oh, thank you. Before we get into our overview slides, just really quick, just want to highlight a couple exception applications that we have available open now. We opened in May, and these will stay open through the end of the year, so through December 31st at 8 p.m. The first one is our Mips Extreme and Uncontrollable Circumstances application, and this gives clinicians the opportunity to request reweighting for one or two or all of the performance categories if you are experiencing an extreme and uncontrollable circumstance. So typically this has been natural disasters or just something that's happened to you or your practice that's been outside of your control. And in recent years, this is also applied to our public health emergency for COVID-19. So that is available application. I think maybe at the end we might have a link to it, but if you go to a QPP website, you'll be able to find it there on our exception applications webpage. And then also we have our Mips Promoting Interoperability performance category hardship exception application that allows you to request reweighting specifically for this performance category to 0%. And there's on the website, we also list the different criteria that you would need to meet to have this exception applied to you. But again, both applications are open through the end of the year. Thank you, Eve. You are on it in the chat. If folks see it, we have links are popping up as I mentioned, so that's great. Next slide, please. All right, and go to the next slide. Okay, so if you have seen any of our previous webinars or looked through some of our QPP materials, you have probably seen this slide before. But we always like to start with it just to orient folks to how the Quality Payment Program is set up. So Medicare Access and CHIP Reauthorization Act of 2015, which we refer to as MACRA, created the Quality Payment Program. So there are two participation tracks in QPP. The first, which today's presentation is focused on, is Mips, so the Merit-Based Incentive Payment System. So if you are a Mips eligible clinician and you will be subject to a performance-based payment adjustment through this track of the program, and the next slide we'll get into in a moment, we'll explain a little bit more about our APMs and how they fit into those two different buckets. But our other track is our advanced alternative payment models. And so if you participate in an advanced APM and you achieve qualifying APM participant status, so you achieve QP status, you may be eligible for a 5% incentive payment and excluded from participating in Mips. Next slide, please. So this slide, we started using this probably 2 months ago or so, but it really helps kind of explain a little bit more detail, kind of where these Mips APMs fit in. So, so while there are these two tracks, the Mips and advanced APMs, the tracks can overlap. So we'll see here that there are the bucket of all eligible clinicians, and then within that, there are certain folks that are Mips eligible clinicians. So the majority of participants in QPP are not participating in an advanced APM and are required to participate in Mips. However, if you are participating in an advanced APM, but you do not achieve QP status or partial QP status, then you are also required to participate through the Mips track. However, if you achieve partial QP status, you have the option. You can choose whether or not you want to participate in QPP through Mips. And then if you have achieved QP status through your advanced APM, you are excluded from participating in Mips. Next slide, please. And one more. The next few slides are, as I said, focused on Mips. So how is Mips structured? So Mips is made up of, the traditional Mips is made up of 4 performance categories. So we have the quality performance category, cost, improvement activities, and promoting interoperability. And as we said today, we are focusing on these last 2 you'll see on the screen, so improvement activities and promoting interoperability. And each of those performance categories has a corresponding weight. So quality for 2022 is set at 30%, and this is a percentage of your Mips final score, which then is how we determine your payment adjustment for the 2024 Mips payment year. So quality is set at 30% for 2022. Cost is set at 30% as well. And both of those, just as a reminder, both of those are required by statute to be set at the mean or median of a previous performance year. So that the lowest we could do was 30%. So that was a requirement. And then Mips improvement activities is set at 15%, and promoting interoperability is set at 25% for 2022. And then again here at the bottom, you'll see some different performance category weights if you are an APM entity participation. So 55% for quality, 0% for cost, 15% for improvement activities, and 30% for promoting interoperability. Next slide, please. Okay, and all of the information on this slide is really just refresher information. As we go through our presentation, you'll hear these different terms. I'm sure the majority of folks on today use these terms all the time, so this is nothing new, but if you can educate someone, that would be great. So TIN, when we talk about a TIN, we're talking about clinician or their practice's tax identification number. When we talk about NPI, we're talking about clinician's national provider identifier. And we refer to a TIN NPI combination a lot of times. And this is how we identify an individual clinician and then the entity or group that they are practicing through. So wherever the clinician bills services to CMS. That's how we determine our eligibility in QPP. And then the chart you'll see here on the screen, this is just a lot of times we are working in this program every day. We have to pause sometimes to remind ourselves, what performance year or what performance period are we in, and what payment year does that correspond? So we just like to put this slide in here as a reminder for folks. So what we're talking about today is 2022 with the 2024 payment year. All right, so this timeline is really gives a good overview of all the different years that parts of the phases of the program that overlap. So as I said, it's always good to kind of ground yourself in what performance year am I talking about, and then what are the different phases related to my performance. So if you start all the way on the left, you'll see this is the performance year that we're talking about. So we are talking about 2022. The performance year beginning January 1st and ends December 31st. And this is when clinicians are you're taking care of your patients and you're collecting all of the data and keeping different records and things throughout the year so that when data submission opens, you have all of that information ready to submit to CMS. So then data submission begins in the following year. So for 2022 performance year, the data submission period will begin in 2023. So opens in January. Typically, we open January 2nd, depending if it's a weekend or not. It might be a day or so after that, but typically January 2nd. And then the deadline for submitting, again, is typically March 31st. Sometimes we fluctuate that a day or so, depending if the 31st lands on a weekend or not. And then this is when clinicians or third-party intermediaries or different vendors that you're working with are submitting data to CMS. And we always encourage clinicians to submit data as early as possible. That way, if you need support, you have time to contact our service center and ask any questions that you might need, or have time to review, or videos and different resources that we provide on our website so that you know how to submit data to CMS. So that is from January through March, and then And then comes our feedback. So CMS provides feedback after data is submitted. So you'll see as you're submitting data, you'll start seeing different feedback information populating as you're submitting data to us. But once that data submission period does end, you start to see you'll see preliminary feedback. So it's not final feedback. So there's different periods where we have preliminary feedback available, and then you'll see final score preview period where we'll see what final scores are, but we won't have payment adjustments information available yet. And then later, typically towards the end of summer is when we have our payment adjustment information available as well. So clinicians will be able to see all of that data that we've processed and that they've collected and submitted to CMS, and how that corresponds to a final score as well as a payment adjustment. And then that payment adjustment wouldn't take effect until 24. The Mips payment adjustments would be applied to on a claim-by-claim basis to cover professional services that are billed under the physician fee schedule, or PFS. And then so that payment adjustment would be applied to all services that are rendered from January 1st through December 31st, 2024. And then the same thing happens the following year. It just shifts to the next performance year, and bumps all the years down past that. Okay, so I think that is enough overview information. Real quick, next slide here. Just briefly wanted to highlight our 2022 annual call for promoting interoperability measures and improvement activities. So every year we have this call for measures and activities where stakeholders can submit either new promoting interoperability measures and or improvement activities to CMS, or you can submit modifications just for consideration for future years of Mips. Nominations can be submitted, so we open February 1st, and they will be available through July 1st. So couple more weeks here, and then they are considered for. Thank you again, Eve, with the quick link in the chat there. They're considered for the following rulemaking cycle. So as we continue doing our rulemaking cycle every year, things that we have been submitted this year are possibly implemented starting not until 2 years later. So it's always this delayed timing. Submissions that are received after that July deadline are considered for future years. So, and again, this year's data submission period will close on July 1st. And then important note here, and you'll hear more about this at our webinar next week, where we focus on the quality performance category, but the annual call for quality measures does have different submission process and deadlines. So please join us next week or look on our website for more information about the annual call for quality measures. All right, I think that is it. Next slide, please. Okay, and with that, I am going to turn it over to Michelle Peterman.
Thank you, Katie. I will be walking us through the improvement performance category for information for 2022. Next slide, please. So for the improvement activity basics, improvement activities intend to improve clinical practice, our care delivery, and outcomes. Clinicians may choose from over 100 activities. We have, I think, about 106 right now, which they're intentionally broad so that many clinician types may complete them. These activities are identified under one of these 8 subcategories listed here in these stop sign looking signs here, including the expanded practice access, population management, care coordination, beneficiary engagement, patient safety and practice assessment, achieving health equity, emergency preparedness and response, and then integrated behavioral and mental health. So there's a box here at the very bottom, so please take note of that information there. That, if you go to the links, you will find the full list of activities on our QPP website. Next slide, please. So for the reporting basics, they have not changed for 2022. Improvement activities performance categories worth 50%, as Katie said earlier, of the Mips final score. The performance period is a consecutive 90-day reporting period. If you're reporting as a group, that would mean 50% of your group must complete and attest to the same IA for 90 days within the performance year. Clinician may gain maximum score of 40 points, which may consist of either medium weighted activities that are worth 10 points or high weighted that are worth 20 points. So any combination of these you can use to reach the 40 points. So in order to receive credit for completion of an activity, the clinician would need to attest to the activity during our data submission period. We do request that clinicians maintain their supporting documentation for activities attested to for at least 6 years in case of an audit. Next slide, please. So for 2022 in our final rule, we did make a few changes to the IA inventory. We added 7 new improvement activities that included 3 related to health equity. We modified 15, and then we removed 6. Like I said in the previous slide, you can refer to this website, to our QPP website under Explore Measures and Activities, and you can search for an activity or review the Excel file that contains our 2022 inventory with all these changes that I've just noted. Next slide, please. And also for 2022, we changed a few of our criteria for the call for IA, which as Katie noted earlier, we are in right now. We originally had only one activity that was, one criteria that was required to be met in order to submit a nomination. So we began the program with this threshold to assist stakeholders to understand the criteria. But now that we've been in the program for several years and stakeholders are familiar with the process, we believe that we needed to increase the requirement as one criteria was a very low bar requirement. So now we are going to require 8 criteria in total to be met for submission of a new IA. So the new criteria are noted here on this slide. The 2 first ones are new criteria that we did not have in our prior criteria. So those 2 are that new activities must not duplicate other improvement activities in the inventory. And then also the second one, new activities must drive improvements that go beyond common clinical practices. When we say common clinical practices, what we're referring to are things that you just would expect to be typically done in a practice. So for example, something basic like taking the patient's vital sign, that we would not consider that an improvement activity. So, and then the 6 below that are also would need to be used as well to submit a new activity. So relevance to existing improvement activity subcategory, the ones that I discussed in the previous slide. The importance of an activity towards achieving improved beneficiary health outcome, feasibility for it to be implemented, especially in light of small practices, rural practices, and our HIPSAs, those need to be considered. Evidence supporting that an activity has a high probability of contributing to improved beneficiary outcomes. Also that it can be linked to the existing and related Mips quality, promoting interoperability, and cost measures as applicable and feasible. And then finally, that we can validate the activity. Next slide, please. Okay, and so these ones here are actually optional factors that we would love for people to include as well. They are not required. So, but although they're not required, we do encourage people to include as many as possible to increase the possibility of the nominated activity being included in the inventory. And these were previous options for the activities as well. So they shouldn't be anything new. Next slide, please. Okay, so now we're going to talk about the IA participation requirements. Next slide, please. So in order for a clinician to receive the highest score in the IA performance category, which is 40 points, so clinicians must attest to 2 to 4 IAs for the maximum of the 40. So the medium IAs, like I mentioned earlier, they're worth 10 points, so you'd have to do 4 of those. And the high weighted are worth 20 points, so only 2, or you can mix them up, which we're going to look at on the next slide. Next slide, please. So, the other thing to mention too is that for the clinicians with the special statuses that we talked about a little bit, the small practices, the non-patient facing, rural or health professional shortage area IAs are higher weighted. So if you're in one of those areas, then your medium weighted IA is going to be worth 20 points and high weighted would be worth 40 points. There's a little box here at the bottom. If you can check your special statuses on our QPP participation status tool. So it's really important to note that if you're submitting data as a group, virtual group, or APM entity, special status designations must be determined at the group level, virtual group, or APM level, the entity level to qualify for these reduced reporting requirements. For example, more than 75% of NPIs billing under the groups 10 must be designated as non-patient for the group to receive the special status. And all those things are laid out on our QPP website. Next slide, please. So for the scoring, this goes over like a little bit of how you can mix and match the different activities to achieve the 40 points. But the big thing is if you don't attest to any of implementing any activities, you'll receive 0 points for the performance category. And we don't want that to happen. So down below, though, it gives you an idea. For instance, the first one's you could do 4 medium weighted. You can mix and match and do 2 medium weighted plus 1 high, or 2 high weighted. So there's many ways that you can mix and match the improvement activities to be sure that you're going to get your 40 points. Next slide, please. Again, for those in the special status designations, since they are double weighted, they would only need to do 2 medium weighted activities for the 40 points or 1 high weighted. There's really no way to mix and match those numbers. So next slide, please. Okay. For those folks that are in patient-centered medical homes, they have a special designation under improvement activities given to us by MACRA. If you are one of those clinicians, you could receive full credit for the improvement test that you are a PCMH and that you qualify for that, but you could get full credit. For organizations with multiple practice sites, which many are, at least 50% of your locations must be recognized as certified patient-centered medical home or comparable specialty practice. We have the requirements laid out in a rule from several years ago, but down below in these boxes, it gives you a layout of the basic accreditation organization that is nationally recognized, be participating in a medical home or medical home model, be a comparable specialty practice that has received recognition through a specialty recognition program offered through a nationally recognized accreditation organization, or have received accreditation from other certifying bodies that have certified a large number of medical organizations and meet national guidelines. So you just qualified as a PCMH under Mips. Next slide, please. So for this one, Mips clinicians participating in APMs or Mips APMs will automatically receive 20 points out of the 40 under traditional Mips. So they automatically get the 20, but they would still need to do more activities to get the rest of the 20. For Mips APM participants reporting via the APM performance pathway, they would receive full credit. They would not need to do any improvement activities. They would receive full credit for being in the APP. Below, there's noted some models that kind of lay it out as to what some examples of, it's not all inclusive, but it's laid out some examples of what Mips APMs or an APM might be. For the full list, there's also under the 2022 Improvement Activities User Guide, which is noted to the far right bottom of the screen on our QPP website, that will give you the full list of everything. All right, next slide, please. Okay, now we're going to talk about the reporting and scoring. Next slide, please. Okay, so to report completion of an IA, the clinician must attest during the 2022 submission period, which is January 3rd, 2023 through March 31st, 2023. The clinicians do not need to submit documentation when testing. However, as I said earlier, we recommend documentation be kept for 6 years in the event of an audit. The documentation guidance, we have a document. It's our 2022 Mips data validation criteria. It will provide you, it's highlighted here with the link. It will provide you with a lot of guidance on specific IAs and exactly what we're looking for in documentation. In this green box below, we provide an example of some of the common documentation. things like screenshots or digital capture of the relevant information supporting the attestation, improvement plans or outlines supporting the interventional strategies or processes. Also, electronic health record reports are also used, but like I said, it's very specific in our validation criteria. It provides a lot of examples specifically for each IA. So it's a good resource to look at. Next slide, please. Okay, and so attestation can be submitted through one of the following submission types. So these three are all found when you go into our reporting tool. So the person who can do it and how they can do it. So who can do it is a clinician or practice representative, and they sign in on our QPP website, and then they attest yes. You go in there specifically to your IA that you have completed, and you say, yes, I'm attesting that we have completed this IA. Another way is that through a clinician or a third party, they typically will sign in and they'll upload a QPP JSON file with the activity attestations. And then there's also third-party intermediaries that they directly submit via computer-to-computer interactions with our QPP submission application program interface or API. More information as well on our QPP website there in the box for you to look further into it. Okay, and then for scoring, it is improvement activities is 15% of your Mips final score, and it's 15% of Mips final score for APM entities as well. The way that we get to this is shown here in a diagram. So we take the total number of points scored for the completed improvement activities over the total number of points, which is 40, and then that's multiplied times 100%. The score is then multiplied by 15%, which is our category weight. The IS score is then added to the other performance categories to determine a Mips final score. So that wraps up the improvement activities portion of this presentation. I will now pass the presentation over to my colleague, Elizabeth Holland, who will be discussing the Promoting Interoperability policies.
Thank you, Michelle. Next slide, please. Okay, we're going to start with some basics for promoting interoperability. This category stresses the use of certified electronic health record technology, or CERT, and patients accessing the information and exchange of information between healthcare providers. Next slide, please. Okay, so for 2022, promoting interoperability is worth 25% of your final score. If you are a part of an APM entity, it's worth 30%. You must have a performance period of at least 90 consecutive days, but you can certainly have a performance period of any length from 90 up to 365. It's your choice. Some measures are performance-based and other measures are attestation-based. And reporting in 2022, you can either use 2015 edition certified EHR technology, 2015 edition Cures update certified EHR technology, or a combination of the two. Next slide, please. Okay, so we had a bunch of changes, and I know I've been answering questions in the Q&A box, but I'm going to go through everything again. So what's new for 2022? Clinical social workers are now also a Mips eligible clinician type, and they are eligible for automatic reweighting of the PI category. And what that means is we would automatically reweight them, but if they choose to submit data, that data would be scored. Same for small practices. You may remember that in previous years, we required small practices, and that's practices of 15 or less clinicians, to submit a Promoting Interoperability Hardship Exception application. We changed this policy for 2022 so that small practices will now qualify for the automatic reweighting of their Promoting Interoperability category. And again, if they choose to submit data, that data will be scored and they will not be reweighted. Another change is we added the high priority practices guide. This is one of the guides in the safety assurance factors for EHR resilience, or SAFER guides. This is a yes or no attestation measure. And in 2022, you can either attest yes or no, and both of those responses would fulfill the measure. We revised the prevention of information blocking attestation statements. The statements are still mean the same thing, but there was some confusion about the separate information blocking policies that were in the 21st Century Cures Act. So now the attestation is now called actions to limit or restrict interoperability. And you need to attest yes that you have not taken any actions to limit or restrict interoperability. We also revised our public health and clinical data exchange objective requirements. It used to be that you could choose any two measures. Now, because of COVID mainly, we changed the policy to require immunization registry reporting as well as electronic case reporting. And for electronic case reporting, since we're aware that many people have not done it before, we added another exclusion if you do not have that. And then the exclusion is only for 2022 if you do not have that functionality in your EHR. We retained the other three public health measures, the public health registry reporting, the clinical data registry reporting, and the syndromic surveillance reporting measures. If you report one of those, or two or three, you will receive 5 bonus points. So you really only need to submit one to earn the 5 bonus points. You don't get any additional points for submitting additional ones. Okay, next slide, please. So you need to participate in the Promoting Interoperability performance category unless you have automatic reweighting, a certain special status, or you have an approved hardship exception. More on this later. Okay, so you may submit a Mips Promoting Interoperability performance category exception application for the following reasons only. The certified EHR technology you're using becomes decertified by the Office of the National Coordinator for Health Information Technology, or ONC. You have insufficient internet connectivity. There are extreme and uncontrollable circumstances, and that would be, for example, if a tornado hits your office or a flood, something like that. Or you practice in a location where you can't control whether you have CERT, meaning that the management of your organization has chosen not to have CERT. And so because you practice there, you don't have CERT as well. If your application is approved for a hardship, we will assign a weight of 0 and move those 25 points to another performance category. If you choose to submit data and you have an approved hardship exception, the submission of data will cancel your hardship exception. So if you have an approved hardship exception, be really careful and don't go in and submit any data because that will cancel it. And you can apply for a Promoting Interoperability hardship exception now, and I believe they are approved on an ongoing basis. Next slide, please. Okay, now we're going to get into reporting and scoring. Next slide, please. Okay, so we have 4 scored measures: e-prescribing, health information exchange, provider to patient exchange, and public health and clinical data exchange. And there are required measures under each of these objectives. Next slide, please. Okay, so as I mentioned before, your certified EHR technology must be either the 2015 edition, the 21st Century Cures 2015 edition, or a combination of the two. And you must have the functionality in place by the beginning of your chosen performance period, and it must be certified by the last day of the performance period. Next slide, please. Okay, so to fulfill the category, you must collect data for the required measures of the 4 scored measures, and in addition, submit the required attestations. So that is the actions to limit or restrict the compatibility or interoperability of certified EHR technology attestation, the O&C direct review attestation, the security risk analysis measure attestation, as well as the high priority practices guide of the SAFER guides. And for the measures, the scored measures, if there's a numerator and denominator, there must be at least a 1 in the numerator if you do not claim an applicable exclusion. Next slide, please. So this gives you a little more detail about each of the attestations that I just mentioned. The query of Pdmp is a scored attestation, which means it's a yes, no, but if you report it, you earn bonus points. And for that would be 10 bonus points. And the public health and clinical data exchange, as I mentioned, if you do one of the 3 optional, you can earn 5 bonus points. And that's also a yes, no measure. Next slide, please. And these are all the measures that are required. So e-prescribing is required. And depending on the numerator and denominator you submit would determine how many points you get for the measure. Same with the provide patients electronic access to their health information that you can earn, depending on your numerator denominator, from 1 to 40 points. If any of these, not the query Pdmp, because it's not required, but e-prescribing or provide patients electronic access, if you submit a numerator of 1, you will fail, and you will fail the entire promoting interoperability performance category if you do not claim an applicable exclusion. And for provide patients health information, there is not an exclusion. Okay, next slide, please. These are the other measures. For health information exchange, you have some choice. You can either choose to do the support electronic referral loops by sending health information measure and the support electronic referral loops by receiving and reconciling health information measure, or you can choose to do the HIA bidirectional exchange measure. The first 2 measures are numerator and denominator number measures, and the second one, the bidirectional exchange, is a yes, no. And either way, you could earn a maximum of 40 points. Next slide, please. And here are the public health and clinical data exchange measures. As I mentioned, electronic case reporting and immunization registry reporting are required. And so you either have to submit a yes that you are in active engagement. And active engagement means there's 3 levels right now. The first level is you have registered with a registry. The second level is that you're in testing and validation with the registry. And the third option is that you're actively submitting data to the registry. So any one of those would fulfill the measure and you could say yes. The same applies for syndromic public health reporting and clinical data registry reporting. And again, if you submit 1, you would earn 5 bonus points. Next slide, please. Okay, so as I mentioned, the promoting interoperability performance categories were 25% of your Mips total score. Since there are bonus points, the amount that you could earn is, if you were perfect on everything, would be 115 points, but we cap it at 100 points. So if you earn from 100 to 115, you would get the maximum 25 points. And just like previously, we sum up all your scores on each of the individual measures, and then we multiply it by the category weight, and that's how we get the number of points that will be contributed to your final score. Next slide, please. Okay. So the way we calculate, this is an example based on e-prescribing, where the clinician submits a numerator of 200 and a denominator of 250. That gets you to a performance rate of 80. And since the measure is weighted at 10, that you would be earning 8 points out of the 10 points for e-prescribing. And we do follow these rounding conventions. Next slide, please. Okay, so for electronic case reporting and immunization reporting, they're both required. So if you submit for both of them, yes, you earn 10 points. If you submit an exclusion for one of them and yes for the other one, you would still earn 10 points. If you claim 2 exclusions for these measures, we would redistribute the 10 points to the provide patient access to their health information measure. And if, again, and this is the same for all measures that are required, if you can't report and you're submitting no's and you can't claim applicable exclusions, you would earn a 0 for the public health objective and a 0 for the promoting interoperability performance category overall. Next slide, please. Okay, so we discussed this. You could earn an additional 15 bonus points if you submit the query of Pdmp and one of the public health, or you could earn 10 or 5, depending on how you submit. Next slide, please. So reweighting. Next slide. Okay, so there's many ways you can be reweighted for promoting interoperability. So you could be a certain clinician type, such as a clinical social worker. You could have a certain special status, such as being hospital-based, or you could have an approved hardship exception. So in these cases, the 25% would be redistributed to another category. Next slide, please. So these are all the clinician types that are eligible for reweighting in 2022. They're automatically reweighted unless you submit data. You may notice that one of the clinician types that are Mips eligible clinician, that's certified nurse midwives, are not reweighted for promoting interoperability, and that's because they were actually participants in the predecessor program, the Medicare and Medicaid Electronic Health Record Incentive Program. So they are not in the automatic reweighting bucket. Next slide. So there are other special statuses. Either you're an ambulatory surgical center based, you're hospital based, you're non-patient facing, or you're a small practice. As I mentioned previously, small practices are automatically reweighted for promoting interoperability starting in 2022. And if they choose to submit data, we will score. That's what this box on the bottom says. If you submit data, we will score your weight and you will not be automatically reweighted. Next slide, please. There are different ways to submit your data. You could do it directly through Attestation. You could upload a file, or you could do a submission via the application programming interface or API. Next slide, please. And I'm turning it back to Katie Moore.
Elizabeth. All right. Hello again, everybody. I know that was a lot of information. Hopefully we've already answered maybe some of the questions you had coming in today, but this next slide, actually we can just skip one ahead. Perfect. So we just compiled a number of resources that we think will be very useful related to today's topics. They can all be found on the QPP resource library, but we just pulled out links to them here. So we have our 2022 Mips Overview Quick Start Guide. That's just a really quick, short hey, what's this about? How do I get going in this program? And then a lot of other resources that we've talked about today are more deep dive performance category guides, as well as our, where to find our inventory for improvement activities, our data validation criteria. There's a link on here as well to our Explore Measures and Activities tool that's found on the QPP website. To encourage folks to check out these different resources to get more information about improvement activities and promoting interoperability. Again, our website is linked here at the bottom. And if you haven't done so already, I encourage everyone to sign up for our QPP listserv, that if you go to any page on our qpp.cms.gov website, at the bottom, you'll see a place to enter your email address. And that is the way that we communicate all of our important information and notifications when we have different resources available or different things are happening and going on with the program. We use that to notify our interested parties what we have going on with the program. So I encourage you to sign up if you haven't already. And then one more resource that is a newer resource, we have a small practices newsletter. That's really, it's not anything new that's different outside of the bigger list of messages that go out, but we really try to take those bigger messages and tailor them specifically to what we think small practices might need, or pull out that key information, and we try to have everything as concise as possible in those monthly newsletters, because we know a lot, especially our small practices, don't have a lot of time to be looking through all this information we're putting out. So if you are interested in that resource as well, encourage you to go to our small practices webpage on qpp.cms.gov, and there's a similar sign up for that monthly newsletter that comes out the first Tuesday of every month. All right, next slide, please. Okay, with that, I'm going to turn it back over to Olivia, who's going to walk us through how we are going to go through our Q&A session today.
Thank you, Katie. So we are now going to start the Q&A portion of the webinar, and you can ask a question via the Q&A box or through the webinar audio. And to ask a question via webinar audio, please raise your hand and we'll unmute your line so that you can speak. Just a reminder, you may be muted on your end as well, so just check to see that you're not double muted. Okay, so to get us started, Elizabeth, we are getting quite a few questions about the SAFER guides. So I'm not sure if you can just go back over that information briefly. We've gotten some questions on when they can be completed, if it's yes or no for 2022, how many guides are required.
Okay, for the SAFER guides, I know it's unbelievable, but it is true that you can attest to yes or no, and that would fulfill the measure. You only have to do the one high priority practices guide review to be able to attest yes. So I hope that that is a policy for 2022. We have not yet established the policies for 2023. So.
Great, and we did get a question if you can clarify how much Pdmp bonus points are.
Pdmp bonus points have actually changed. For 2021, it was 5 bonus points, but for 2022, it's 10 bonus points.
Great, and then the next question, where can we find a list of conditions that can be reported through electronic case reporting?
I honestly don't know. It depends on the state, I believe, or which registry you're using. We do have a discussion of electronic case reporting in our final rule from last year that I think you can get to from our QPP resource library. That would be the physician fee schedule final rule that we released in 2021.
Great. And the next question, if a small practice chooses not to report PI and the automatic reweighting occurs, what is the allocation for the weighting for the quality, cost, and improvement activities categories?
It would really depend on how many categories are being reweighted. Generally, the 25 points goes to quality, but it depends on the allocation for all the other categories as well.
Thank you. And we are getting a few questions related to the extreme and uncontrollable circumstances. So this question reads, what are the EUCs considered for the categories this year? Could you expand on this and if the pandemic affects this?
Sure. This is Katie again. I could take that one. So I was just looking at that. In the past couple of years, actually 3 years, so I know for 2019 and 2020 and 2021, we had automatic EC policy applied to all Mips eligible clinicians. That is not the case for 2022, so I think that's an important distinction for folks to be aware of, that our extreme and uncontrollable circumstances policy is not being applied automatically for COVID-19 for 2022. You still, if you are still being impacted by different effects of the pandemic and would like to request reweighting due to that reason, you definitely have that option through the application. And so encourage folks to submit those applications to us if you need to. And then we do have, I believe we have one, currently we have one automatic EC being applied for a few different areas in, sorry, I'm going to forget off the top of my head. But we have it on our automatic EC fact sheet. We have listed due to a recent natural disaster.
Thanks, Katie. So the next question in the Q&A box, are groups going to be automatically reweighted for PI, or do only individual clinicians qualify for this exemption?
I'm sorry, the automatic reweighting of PI? Could you repeat the question?
Yes, of course. It's, are groups going to be automatically reweighted for PI, or do only individual clinicians qualify for this exemption?
Well, it would be small practices. So if you're a group of 15 or less clinicians, then you would be considered a small practice, and then you would be reweighted. So if you have one person in your practice, you would be reweighted, or if you had 15 or less, you would be reweighted.
Thank you. And then just another question on Pdmp. It reads, what is the appropriate documentation to maintain to show compliance with a Pdmp query process?
I believe we have that on our website. I can try to dig up the link and post it.
Okay, and we have gotten some folks raise their hand through the phone line. So Martha Sullivan, we will unmute your line and you can ask your question. And Martha, you may be double muted, so you may have to unmute yourself. Okay, the next person, oh, sorry, go ahead.
Yes, I was saying that I must have accidentally pressed something, so I apologize.
no problem. Okay, we will go to the next person with their hand raised. Mary Kay Taylor, we will unmute your line. You can ask a question. Oh, okay, we will move on to the next person, Martha Sullivan. We will unmute your line and you can ask your question.
Oh, Olivia, I think that was Martha from the first time.
Oh.
Yep, I'm not moving my mouse
Okay.
anymore, so I won't cause any more problems.
Okay, perfect.
Good to hear you, Martha, but thank you.
Well, we'll shift back to the Q&A box for now. So just a few more questions. If you are hospital-based, do you have an option to report PI, or are you just automatically reweighted?
Well, you have an option to submit it. You're automatically reweighted unless you choose to submit data, in which case your reweighting would be canceled.
Thank you. And then the next question is for you, Michelle. For syndromic surveillance, does each TIN have to have an urgent care in order to attest IA?
I just sent that person a follow-up question. I'm not sure what IA they're referring to, the syndromic surveillance. Can they provide me more information?
Yes, so if you submitted that question and want to just provide a little bit more information, we can come back to it.
Yes, please do. Thank you.
Yeah, or feel free to raise your hand. I'm calling you. Sometimes it's easier to chat than to try to type everything you're saying.
I think
another question.
sorry, this is Michelle. I think they were referring to PI. The person just sent back, sorry, I meant PI. So that's the clarification on that one about the syndrome.
Okay. The next question, what counts towards the bidirectional HIE? Would you have to have an HIE with all places you refer?
We lay out the criteria in our final rule, and there's more information. We do have specification sheets in our resource library, and they are for every measure, and they go into detail about what's required for the measure. And so I would recommend looking at the specification sheet.
Great, thank you, Elizabeth. And then one question that just came through, if we report COVID vaccinations through our state immunization registry, but no other immunizations, can we attest yes to the electronic immunization registry measure?
Yes.
Perfect. And I think we can shift back over to the phone line one more time. So Debbie Krager, your line will be unmuted and you can ask your question. Debbie, your phone line might be muted on your end. Okay, might be having some technical issues. One more person has their hand raised. Katya Avakin, your phone line will be unmuted and you can ask your question.
Hi, everyone. Thank you for an insightful webinar today. I have rather a rudimentary question to ask. So I was under the impression only physicians report on the Mips and they get bonus on their fee-for-service billings. But I saw that you mentioned a lot of other clinician types as well, like clinical social workers, nurses, and PAs. So am I right in interpreting that these clinicians also report on Mips and they get bonus points on their fee-for-service billings?
I gotcha. Thank you for your question. So yes, there are a lot of different clinician types that are required to participate in Mips outside of physicians. So yes, so all of the different clinician types in the program, if they are required to participate and submit data to CMS, they would receive a final score depending on how they participate in the program, and then that final score would equal their payment adjustment.
Sounds good. Thank you very much.
This is Michelle. Just a little bit more on that one. You can see all of the Mips eligible clinician types on the QPP website. There's quite a few. So please refer there, and you can just type in Mips eligible clinicians and it'll pop right up. So you can see the list of who all's involved.
Sounds good. Thanks, Michelle.
Sure.
Great. And then I think we have time for a couple more folks who have raised their hand. So Liz Lund, we will unmute your line and you can go ahead and ask your question.
Oh, and real quick, when folks speak up, would you mind just introducing yourself and saying what organization you're with? That'd be great.
Liz, I think we unmuted your line, so you may have to unmute on your end if you want to ask your question. Okay, we will move on to Lorraine Nardi. We will unmute your line.
Hi, I asked a question before about, are the PI measures that are attestation only, if that's the way you want to do it, are they the same as the previous year?
There's one additional one, the safer guide is an attestation.
Okay.
Fulfill a yes or no, but everything else is the same.
Everything else the same? Okay, great. Thank you so much.
Great. And we will go next to Ashley Tully. Ashley, we will unmute your line.
Hi, thank you. My name is Ashley Tully. I work for a quality consulting firm. One of the questions that I've had is on the 2022 PI performance category user guide. On page 18, it specifically states that the automatic reweighting for special statuses for small practices, that if the small practice has the PI automatically reweighted, that part of it goes to improvement activities and part to quality, which is drastically different than the EUC reweighting. So I just wanted to clarify that that is actually the case, that the reweighting is different for just small practices if they take the automatic hardship exception versus if they apply for any of the EUC.
Sorry, Elizabeth, are you able to answer that one?
I'm not sure.
Okay.
Okay.
And
Yeah,
I can submit a ticket. I suppose it's just, like I said, the reweighting is drastically different for the automatic reweight versus the EUC. So.
And you're talking about when you say well, are you talking about the automatic, sorry.
Oh, I'm sorry.
EUC application, or are you talking about the PI hardship application?
So let me clarify further. So on page 18 of this guide, it also breaks down if you are a small practice and have the PI automatically reweighted, but then it also goes further to break down if you also have cost reweighted. So for instance, in this guide, if you're a small practice and you reweight PI automatically, and my assumption is if you have cost reweighted based on the COVID-19 EUC hardship if you apply for it, your IA and quality is 50-50. But then if you look at the EUC reweighting guide, then those weights are drastically different. They're more shifted to quality than improvement activities. So, you know, for a small practice, that's a huge difference when they're trying to calculate whether or not they should report. So I just want to make sure if they're a small practice that they can default to this guide, not the automatic EUC. Like that's not going to overtake what's on this document.
Let me double check and look. This is Katie. Let me double check and look at what you're seeing just so I can make sure I'm giving you the right answer.
Thank you.
And yeah, and why don't Petition team, if we can get Ashley's information, that way I can just follow up with you directly.
Okay, perfect. I'll put it in the chat. Thank you so much.
Okay, great. Thanks.
Okay. We will go to a few more folks who have raised their hands. Mark Holstrom, we will unmute your line and you can ask your question.
Good afternoon. I'm Mark Holmstrom at Mountain Area Health Education Center in Asheville, North Carolina. And I have a follow-up question to what I put into the Q&A regarding reporting improvement activities as a participant in a Mips APM. What we're used to is, okay, well, my practice is part of a Medicare Shared Savings Program, ACO. What we're used to doing is going in and choosing the traditional Mips, reporting only PI, and then the ACO handles quality and improvement activities. This, you know, slide 26 confuses me a little bit. Is that process changing? Do we need to report something in PI and improvement activities, or is the process still the same that the ACO handles improvement activities and quality?
This is Michelle. As far as I know, the process has not changed, but I would definitely check with my ACO and confirm that and be sure that everything is still status quo.
Okay, thank you.
Yep.
Great, and we will now go to Catherine Harris. We will unmute your line and you can go ahead and ask your question.
Hi, yes. I just wanted to ask, how will CMS reimburse ACOs under Mips?
Hey, Catherine, are you asking just like in how will they receive their Mips payment adjustment?
Yes.
I'm not an ACO expert, but I believe it's just, I mean, it's nothing different this year than how they've always received their payment adjustments from CMS. And I don't think we have anybody from our ACO team on the phone today, but if you have more specific details on the question, you could submit it to us and we'll try and get back to you.
Okay, we will go ahead and go to the next person. Jessica Peterson, we will unmute your line and you can ask your question.
Hi, thank you. Yeah, my name is Jessica Peterson. I'm the Vice President of Health Policy at Marston Advisors. We're a Mips consulting firm. I just wanted to answer a previous person's question about the reweighting from the 2022 Mips Promoting Interoperability User Guide, page 18. That reweighting scenario is the same for small practices, regardless of how they get the hardship or the exception. Doesn't matter if it's an EUC or an automatic. In the last final rule, CMS finalized different reweighting scenarios for small practices versus large practices to take into account the differences in the ability to do well in the quality category. So when PI is reweighted for a small practice, IA is 30, quality is 40, cost is 30, When PI and cost are reweighted, IA and quality are both 50. And when PI and quality are reweighted, IA and cost are both 50. So that was what was finalized, and that's pretty consistent across the guides.
Thanks, Jessica, for jumping in. Appreciate that.
No problem.
Okay, we have a few more folks with their hands raised. Anas Munir, we'll go ahead and unmute your line.
Yes, hi, everyone. This is Anas, and I'm the quality manager in healthcare management services based in New York. I just wanted to ask one thing, that for suppose, what are the other reasons where we can apply uncontrolled and extreme and uncontrolled circumstances other than COVID-19?
Sorry, Anas, did you say other than COVID-19?
Yes.
Yep. So each application is reviewed on a case-by-case basis. So you would just, I believe there's a link in the chat, but you just go to the application. It's pretty simple. There are a few drop-down options, I believe, but otherwise you just kind of let us know what the different scenario that you're facing, and then we'll our team will reply to you directly.
Katie.
All right.
We will now. Great. Okay, we will now go to Sharon Tompkins. Sharon, will unmute your line. And Sharon, you may be muted on your end.
I'm sorry, can you hear me now? Sharon Tompkins, Next Gen Healthcare.
Yeah.
I wanted to get a little bit more information about what you said for the fourth exclusion for the ECR reporting. So is that because the states themselves are just not ready, not all the states, and the Ames reporting is so far behind? And is that something we can expect to see in the QPP proposed rule coming out in a few weeks? In the next few weeks, let's hope to say.
Let's hope.
Yes, right.
The electronic case reporting exclusion, the one that I mentioned that's only good for 2022? Is that the one you're referring to?
Yes, ma'am. Yes.
Okay, so the reason is that electronic case reporting previously hasn't been required, so that many EHRs, we have learned, have the functionality, but they didn't get it certified. So the exclusion is if you have the functionality, but it's not certified, your vendor's going through, and when we were establishing the policy, vendors were quickly getting their functionality certified. So it just gives everybody a little more time to make sure they have the certified version of the ECR functionality.
But what if they do?
It's only for 1 year.
I'm sorry, I cut you off and I didn't intend to. My apologies. What if they do have the certified version of the EHR, but the states and Ames are behind on their testing?
That's and you can still meet the measure if you've registered.
But they're turning down registration because the testing is incomplete.
As long as you have an email sent to them or a screenshot or something that says you want to register, if the onboarding is delayed because of them, as long as you try to register, that would fulfill the measure.
Thank you very, very much. You made my day.
Okay.
Thank you.
Great. And we'll now go to Larry Tufts. Larry, we will unmute your line and ask your question.
Good afternoon. This is Larry Tufts, I'm Regulatory Program Manager here at Baptist Health out of Jacksonville, Florida. I saw a couple questions in the Q&A around this topic and wanted to get confirmation as our health system will be changing EMR vendors mid to late year, and have seen some documentation on the QPP website that you can apply for a Mips Promoting Interoperability performance category hardship exemption or exception if you do switch CHIRT vendors during a performance period, and saw some of the answers as a no within the Q&A today. So I guess just to make it crystal, would it be appropriate to file exceptions before our transition to a new EHR system? Just to be on the safe side, to have that safety net there in the event that we do find that after we transition to the new EHR, that data is not appropriate or not correct, and it can't get it fixed in time for a 90-day period.
Sorry, I've been typing so much. I'm trying to pull up stuff to see where we are here. I was trying to go through the slide deck to bring up the page where we talk about the reasons why you could submit a hardship. So the reasons are if you have decertified EHR technology, if you have insufficient internet connectivity, if you have extreme and uncontrollable circumstances, or if you have a lack of control over the availability of certified EHR technology. If you meet one of those criteria, you can file a hardship. The reason we don't have one for switching EHRs is because the performance period is only 90 days. So if you have January 1st through March 31st, let's say, that's 90 days. And if you switch mid-year, you can use that first reporting period.
Okay. I guess the reason why this is a question for us is that our current technologies don't meet the public health reporting requirements specific around electronic case reporting, since that is obviously new to everyone this year. But that's our own special case. And again, just kind of trying to be as proactive as possible with this migration to a new EHR and kind of protecting ourselves while our new EHR will have that functionality. So
Right, understood. And that's why there's that special 1-year exclusion that you could apply for ECU, for electronic case reporting.
Okay, well, thank you very much.
Sure.
Great. We will now open the lineup to Thoma Hudson. We will unmute your line.
Okay, can you hear me?
Yes.
You can, okay, thank you. I'm thinking, oh, I don't know what to push. This is quick, but this is on the HIE bi-directional because we keep going round and round about this. So I know I pulled up the fact sheet like was suggested, and it says at a minimum, this includes all transitions of care and referrals that are ordered by the Mips eligible clinician. And then when you scroll on down to the additional information, it discusses the enabling the ability to query for or receive health information for all new and existing patients, yada, yada, yada. Anyway, my question being that the NHIE in my mind is, as you have stated, or in the fact sheet, it's a network or something. We use a HISP when we're sending referrals, but we're also active in a bidirectional HIE where we do query and send information for all patients. And I guess that's they're kind of two different things. And that's where my organization goes round and round about whether we can meet this or not.
As long as you are participating in a bidirectional exchange and you're querying, I think you meet it.
Okay, thank you.
Great, and I think we have time for one or two more questions. So Gwen Franz-Grote, we will unmute your line. Gwen, you may be muted on your end. Okay, it looks like we can go to somebody else. Uzma Irfan, we will unmute your line.
Hello, I'm Usma Irfan. Can you hear me? Hello?
Yes, we can hear you.
Yes,
Yes.
we can hear you.
I have two questions. My question is on for small practices. So what is the difference between application for hardship application and automatic exclusion for small practices for PI categories? Interoperability, I'm sorry.
For the hardship exceptions, those were the 4 reasons I just mentioned.
Yes.
Provide cert, et cetera. And the automatic exclusion for small practices applies only to those small practices. That's groups of clinicians that are 15 or less clinicians. They would automatically be reweighted. So the reweighted happens depending on your size, and the hardship exception for promoting interoperability needs to be one of the different categories that we have exceptions for, and you need to apply for it, and you can apply for it now.
Yes, so for automatic exclusion, what will be the process? Will there be a process or it will be just automatic?
It will be automatic. You should be able to go in, I don't know when the lookup tool will be available, but you should be able to go in and check your Mips status for 2022, and it will tell you if you are being automatically reweighted because you're a small practice.
That's good. Okay, I have one more question. Yep. Safer guide review. So can you explain the safer guide review? Is it correct that we will need to just review a guide and attest it, or it is something else? Am I missing something?
Yes, you just need to review a guide. It's the High Priority Practices Guide. And for 2022, you can review it and say yes. And if you do not review it, you can say no. And either one, a yes or a no, would fulfill the measure.
I understand. So does the clinician have to review it, or manager can review it too?
It could be someone in the group.
It can be someone in the group. Okay, sure. Thank you. Thank you.
Sure.
Perfect. Well, we are coming up on time, so that actually concludes the Q&A portion of this webinar. And Katie, we'll turn it back over to you to close us out.
Okay, great. Thanks, Olivia. And thank you so much, everybody on the line today, for participating and for joining in. That was a great Q&A discussion. And please be on the lookout for slides in the next week or so. And also, we have the quality and cost performance categories webinar happening next week as well. So please check out our webinar library for how to register for that one. Thanks. Have a great day.